Hello, it's me again. Thank you for the opportunity to discuss another topic with you about cardiac rehabilitation. And we have a few studies, but I selected one. It's from a thesis of my student in Brazil, so I will show you our established findings and some preliminary results that will soon publish as well. So again, I must disclose that all my research is funded by public agencies from state and national agencies. So I believe you are aware that cardiac rehabilitation is necessary treatment in Brazil as worldwide. So in Brazil, we don't have a lot of centers establishing cardiac rehabilitation so far. Most of the centers available are in the southeast and south of the country. It's a big country, so the north, northwest, and the central part of the country does not have several cardiac rehabilitation services. So it's still a challenge for us to perform such an intervention. But it's quite important for our country because cardiovascular diseases is the leading cause of death and disability in our country. So despite the well-documented effects of these interventions, global participation, which is a major problem, even when we have available systems for cardiac rehabilitation, barriers are too strong. Despite the brilliant presentation from Professor Imamura earlier, we have coverage for the public system for everyone, but personal barriers does not allow people to join most of the services. She already spoke about the time for some service to be available. So we believe that barriers for cardiac rehabilitation is still a challenge for our people and probably in other countries too. So we usually assess functioning as functional capacity, muscular function, balance as well. But we sometimes forgot about the psychological aspects of the rehabilitation, as well spoken earlier about the biopsychosocial model. I was very happy to see this mentioned here. In Brazil, this is a very strong view of the biopsychosocial model. So we conduct a series of studies aiming to evaluate the barriers to cardiac rehabilitation. And we try to predict, again, using complex statistical models, try to predict whether these barriers will affect participation and functional outcomes. So this is a well-known scale for cardiac rehabilitation, barriers for cardiac rehabilitation assessment. It's an easy scale to use. It's a Likert scale with 5 options. It has 5 domains: to comorbidities and functional status, perceived needs and healthcare functions, personal and family problems, work and time conflicts, and access. I believe we are thinking about what this means for us. It's difficult for us to have time for the gym. We want to be with our family. We have to manage time, working time and leisure time. So I believe these are commonplace for us too, not only for patients. Imagine for those in the need of rehabilitation. So this scale is interpreted as higher scores means higher barriers. So we conduct the doctoral thesis from Gabriel Parisotto. This thesis is available in full if you want to reach. But it has 3 main studies. One is already published, short time, 30 days follow-up, observational. Newly accepted paper 2 days ago in time for this presentation. And 1 preliminary results for a 1-year follow-up. We are finishing now in September, just finished in September, and we'll proceed to publication soon. So in our first study, we try to examine whether functional status at discharge predicts barriers to cardiac rehabilitation 30 days later. So 30 days is very short time, but it's important because within this time frame, we already have readmission. So we believe that within this time frame, we give us some hint about why people came back to the hospital. So for this cohort, we have 130 patients with acute coronary syndrome, discharged after ICU, international admission. We assessed at their discharge functional capacity, the 6-minute walk test, respiratory muscle strength, peripheral muscle strength, hand grip, and we applied it 30 days later, the scale for barriers for cardiac rehabilitation. So we try to predict whether functional characteristics at discharge will say, what this will say about the barriers for them. And of course, we adjusted for common confounders such as age, sex, body mass index, severity score, the GRACE score, and length of stay. What we found was the main barriers were related to functional aspects and comorbidities, as expected. And we also saw that perceived need and healthcare factors were a main barrier for them. And work time conflicts seems not to be a problem for them because who can access this service mostly were private ones, so they have funding. They can fund it in the rehabilitation. But most interesting find was that inspiratory pressure was a predictor of barriers. So people who has better respiratory function showed lower barriers for cardiac rehabilitation. It's an important finding because we show now that functional aspects can predict whether you can continue accessing cardiac rehabilitation. Not only for the functional aspects, but also for the perceived need of the patient. So we continue the study and try to predict now whether this would affect hospital readmission, admission again within the same time frame. So we increased our cohort size to 320 patients. We applied the same instruments, 6-minute walk test, respiratory muscle strength, peripheral muscle strength, all them at discharge. And 30 days after discharge, we again applied the scale for barriers to cardiac rehabilitation and performed the same adjustments. What we found was that a lot of these outcomes were interrelated. Of course, functional assessments in the top square are also interrelated. Cardiac rehabilitation barriers on the lower rectangle are also interrelated, but we can see that CRBS for the functional assessment is strongly related to functional assessment. So there's a dimension of cardiac barriers, but barriers for cardiac rehabilitation that we can capture using functional assessment. They are related. And what we saw is for the short time frame, within 30 days, 6-minute walk test predicts, and maximal expiratory pressure predicts short-term readmission. So if the patient leaves the hospital with better functioning, his chances to readmission is lower. It's very important because we have to discharge our patients with the best functional as possible. And we also show that those barriers were also associated to readmission. So patients who had more barriers were readmitted more. And so their risk is higher for readmission, even if they had better function. That's an important aspect. And we show that functional capacity predicted the severity of the barriers. So if you have lower 6-minute walk test, for instance, you have a higher score in various for rehabilitation. So then we continue our study. We increased our follow-up to 1 year because, again, 30 days is very short time, not too much events for a statistical finding. So, and substantial. So we extended to 1 year. Our current cohort analyzed this with 58 patients of 140, which we completed last month. And we repeated all the assessments, but just added a phone call to ask them if they readmitted or if the patient has died. So what we found is that what we believed, what worked in the short time, the 30 days, did not predict in the long time. Functional assessment in the short time was better to predict readmission than to predict mortality at 1 year. But remember, our cohort is small. It's only 58 patients. We have to wait for all cohorts to present our findings. But we also show that higher scores in the psychosocial domain better predicts mortality than functional assessments alone, even after adjustment for confoundings, age, sex, etc. So what this highlights? This highlights that in the short term, we have functional assessments as good indicators of discharge, of readmission, and better and lower barriers to rehabilitation. But at larger times, we have to improve our assessments and include another measures, not only functional, but more comprehensive assessment that embraces the biopsychosocial model, not only 6-minute walk test or respiratory function. So within this framework, we developed a conceptual model that we must, at hospital discharge, always evaluate functional assessment. Given that functional deficits are present, we must assess their barriers to try to decrease them at discharge, because in the short time, they will appear as an important limitation for their improvement. When you have physical barriers, you have to think about early readmission. Patients may be hospitalized again in the short frame because they have barriers for their rehabilitation. And we have to consider biosocial factors because they are associated with late mortality, at least in this cohort. And again, we have to wait for the final results, but it's already a finding. So what are the take-home message? We must evaluate at discharge our patients. So because this evaluation is important to predict the risk of readmission, of mortality. We have to apply the scale for assessment of barriers because it's an important measure, objective measure for follow-up. During early recovery, within the 30 days follow-up, we should integrate, as possible, exercises for improving lung function, improving musculoskeletal function as possible, because the better the patient is discharged, the lower the chances to readmission and to have strong barriers. And we have to combine this in research because this is only one study. We have to perform more studies in other centers, with larger cohorts, to show if this is, in fact, well generalized effect. So again, this is not a one-man work. Gabriel is the student who defended this thesis, just approved. This last work was awarded in a national congress 2 months ago. So Professor Luis, Mauricio, and of course, I believe you know, Professor Yannis is also a collaborator for this project so far. And I could not help myself to show that you are a long-time friend and long-time partner. So we went to Brazil about 8 years ago, and I'm very happy to be here to give to. Okay, thank you very much.